As an oncologist, there are many issues that you have to cover with a newly diagnosed woman with cancer. If your patient is a young woman with cancer, fertility preservation should be front and center and must be discussed early in the process because of the risk that chemotherapy or radiation can cause premature ovarian failure.
It's really the oncologist's responsibility to address fertility preservation with any patient that they see of childbearing age prior to initiation of systemic chemotherapy. And we know based on the ASCO guidelines this is required of us, but many times it's forgotten. I think there's so many things that are happening at an early diagnosis of breast cancer or any cancer of that nature, and trying to coordinate the treatment, trying to coordinate the schedules, additional biopsies that might be required prior to initiation of therapy, that many times this particular risk is lower on the priority list, and therefore it is forgotten.
There are many ways to have the conversation about the risk of infertility and options to preserve fertility, whether it's during the initial phone call, the first visit with the oncologist, or the chemotherapy consent visit. But these conversations need to happen soon after the cancer diagnosis and before treatment begins.
What we've tried to do at our center is introduce the concept of fertility preservation from the very first phone call. So it's actually on the list of questions that is asked of patients as they are coming in to set up their medical and surgical radiation oncology appointments, but also for women who are of childbearing age to also be asked if they would like to speak with a reproductive endocrinologist and infertility specialist. And many of our patients are unaware of that risk when they're coming in the door. So we're hopeful that that will increase awareness to the point that they'll start thinking about it.
So we have the initial consultation where I make recommendations for chemotherapy. And then we have the patients return for a chemotherapy consent visit, because that permits the woman to kind of get accustomed to the idea and then come in again just focused on the specific logistics and the details about chemotherapy. And that's when we really focus on fertility preservation options by specifically asking the woman, are you desirous of future fertility? And that question alone opens up that option. Sometimes I'm surprised at the answer. Might be a young woman with a large family, might be a woman without a partner, or you can be surprised. It's really one of those questions where you don't know the answer until you ask the patient what her own desires are.
Many practices are currently falling short on talking to patients about the risks of infertility and fertility preservation options. Statistics gathered in 2012 from ASCO's Quality Oncology Practice Initiative show that less than 1/3 of patients of reproductive age had discussions with oncologists about risks of infertility from treatment, and less than 16% of patients had discussions regarding fertility preservation options or were referred to a fertility specialist.
I wasn't initially aware of a gap in recommendations for fertility preservation counseling until my practice enrolled in ASCO's COPE program. Fertility preservation is one of the COPE measures, and the practice, we submitted our charts and realized that we were missing some of the patients who were appropriate for fertility preservation. Several years ago, I initiated a practice quality improvement project specifically to increase our performance on that measure.
The main options for preserving the fertility of a woman who has to go through cancer treatment are embryo and oocyte cryopreservation and oophoropexy.
I do think that they need to be knowledgeable about what is required in broad strokes for each of the techniques. I think the most important thing is for there to be a partnership with the medical oncology team and the reproductive endocrinology and infertility team, so that there can be a very fluid referral process, and that it doesn't take days and over a week to make that referral, but rather a well-oiled machine so that patients can go from diagnosis to reproductive endocrinology and infertility. Decisions can be made quickly and then returned back to the medical oncologist for treatment of their cancer.
It's actually very gratifying for a medical oncologist to have counseled a woman who's desirous of future fertility, make her aware of the risk of the treatment that's going to be rendered, help her get in the door with an expert in administering assisted reproductive technologies, and then down the road for her to have to bring a happy, healthy infant into the office during one of her survivorship visits.
There are numerous resources available that provide information for cancer care professionals and people with cancer. ASCO's guideline on fertility preservation in cancer patients was updated in 2013 and offers guidance to practicing oncologists about available fertility preservation methods and related issues in people treated for cancer. There is also a case-based course on fertility preservation in the Focus Under 40 curriculum on ASCO University. And for patients, a host of resources is available on ASCO's patient information website, cancer.net, and on the website of the Livestrong Foundation, livestrong.org. The Livestrong Fertile Hope Initiative is dedicated to providing free reproductive information, support, and increased access to fertility preservation services for those whose fertility is at risk due to cancer and its treatments.